So now what about those cysts that we really worry about, the cancers, the malignant neoplasms? Well, these don't look anything like what we've been talking to up to now. These, if they're complex cysts, have large solid components. They do have septations. They have blood flow in the septation. They have flow in the solid components. They're thick. They're irregular septation. Often they're associated with free fluid, and the free fluid carries the malignancy throughout the abdominal cavity. And since it's in malignant ascites, it shouldn't surprise you that it often affects the edge of organs like the periphery of the liver. It can directly invade the peritoneum itself, and it can cause involvement of the omentum, which can cause thickening, and they tend to be large. So these masses look nothing like what I showed you before. All three of these people have ovarian cancer, and it's important to recognize that the appearance just doesn't, it looks very ominous. So these should all come out. They have flow. They really shouldn't cause you confusion because they look so different than the 6 lesions I've shown you. Flow and septations can't be ignored, although they will not always be due to malignancy. Fortunately for this woman, this was a benign lesion that was septated, and sometimes you can see that with an endometrioma, but they must come out. And finally, occasionally you can have masses that look ominous, and the pathology tells you that they are not cancer, they are benign, often benign neoplasms. So here we have a case where there is ascites, there was an ovarian mass, to give you the opportunity to evaluate it further. Change your transducer now to a superficial transducer and realize that you're dealing with an implant here in the peritoneum itself. Or go to the outside of the liver here, the periphery of the liver. That's where tumors like to go, the periphery of organs. So that is a tumor implant in a lady who has a small ovarian cancer. And here we also have a peritoneal implant in addition, so that patient has both. Here we have omental thickening with bowel displaced away from the abdominal wall. What about this case? I believe this may be my last case. It looks like it could be complex fluid, but you can never say that because you don't know until you put color on. This component had no flow, so it's probably hemorrhagic, so you might not need to follow it. But the other component, unfortunately, was not cystic, was not complex in terms of complex cyst, was a solid mass, and this has obviously flow. We have to be worried, and therefore we were right to be worried. This patient actually presented with a primary tumor in the lung of unknown etiology, and by doing this ultrasound, we were able to say for sure that this was not a hemorrhagic process. This was a solid mass in an ovary due to, in this case, ovarian cancer. So now we have the big 6. I hope you know, as you're looking at them, to recognize them, know what to do for them, not to worry about them. Patients will often go to surgery based on their clinical presentation with these, not necessarily based on ultrasound. So to put everything into summary, premenopausal woman who has what looks like a small follicle or corpus luteum probably don't need to even report it, and certainly don't need to follow it up because this is part of a normal menstrual cycle. As we get larger, you want to report it, but no need to do a follow-up because these should resolve on their own as functioning follicles and functioning corpus lutea. Premenopausal cyst, still unilocular, getting larger. Probably do want to follow it up, make sure that it is not growing, or if it is growing and if it's growing, probably should come out because these will be neoplasms, but benign, those cystadenomas that we were discussing. Only when we get to be greater than 7 centimeters should we consider taking them out, according to the people who wrote the consensus statement. Hemorrhagic cysts initially do a short-term follow-up because most likely it will be a functioning cyst at this point and will resolve. But if they are large, follow it up because sometimes endometriomas can also have this appearance and can cross over in their appearance with that of a hemorrhagic cyst. If you have a postmenopausal woman and you have a very small, that is less than a centimeter cyst, consider not even mentioning it in your report. Greater than 1 centimeter, between it and 7 centimeters, do yearly follow-up because we are thinking that these are going to be benign neoplasm. That means a benign cystadenoma. If you have a hemorrhagic cyst and the woman is early postmenopausal, our gynecology clinicians urged us to do a short-term follow-up because most likely if it's shortly after menopause, it may still be a functioning cyst. They mentioned that women can occasionally ovulate within 5 years of menopause, which came as a surprise to me. But after 5 years, they said you do not ovulate anymore and you would be worried about a neoplasm. Frankly, I am worried about all hemorrhagic processes after the menopause, even these early ones. Remember I said that ovarian cancer rarely hemorrhages, but occasionally it can, and so I would be worried about a neoplasm because I never want to miss a neoplasm if I can help it. And finally, if you have a pre- or postmenopausal process that looks like a dermoid, it probably will be one, and you can follow those providing they're less than 7 centimeters. If it's unilocular and large, it's going to be a benign neoplasm, such as a cystadenoma, which our pathology colleagues again suggested does not transform into a malignant cystadenocarcinoma. All the other appearances that we see, septation, mural nodules, solid masses, we will worry about a neoplasm, and those should come out because we cannot say, unless you see ascites and spread of tumor, if it's benign or malignant. That's the pathologist's job, and we're happy to let him do his job after these ovaries are removed. So fortunately, most women have ovaries that look normal. We recognize them. But when we see things that are variations or out of the normal range, we know now how to handle them. Many of these are going to be physiologic or functional processes that will go away. Some will be neoplasms, such as dermoids, that we know what we recognize them, or hemorrhagic cysts, so we recognize those also and know how to treat them. I again thank Dr. Netter for his help in preparing this talk, and certainly I thank you also for your attention.